hello everyone online. My name is Sriharan. I am from the Schulich School of Business and I do research around health human resources and organizations. So it's wonderful to be here and moderate this panel on EDI and anti-racism initiatives in the health workforce, especially in a context where we are seeing like about over 75% of health workers are women or people who are self-identify as women. And in certain professions, it's somewhere around 90 to 99% of them are considered female or women. And then the other thing that we are seeing is also in medicine and nursing, the health professional training pipeline is now more diverse of racial, ethnic, gender diversities. But our policies and organizations are not aligned to that. So we have wonderful panelists today, starting with Stephen Gannon from UK, from the FIAT Training Cultures Program lead at the GMC, General Medical Council. And then online, we have Faith Mitchell. She's a fellow at the Urban Institute, Washington, DC. And then from online again, from Canada, Professor Bukola Salami from the Cumming School of Medicine at the University of Calgary. And then on video from Australia, Jayde Fuller, the National Director for the Aboriginal and Torres Strait Islander Health Strategy Unit at the Australian Health Practitioner Regulation Agencies. So I'll ask Stephen to join us first.
Thank you, Abby, and it's a privilege to be able to be here to talk to you about the work of the General Medical Council. So we've got a programme of work called Fair Training Cultures, and one of my colleagues in 2019 came to talk at this event, and the work at that point was called Differential Attainment. The work at that point was to explore the data and the research to understand what differential attainment means in terms of exam outcomes, assessment outcomes, and other indicators that we can kind of explore. 4 years later, we've now kind of moved that work on to action-based. We're building this work into our standards, our policies, our processes, and our quality assurance. So I'm going to talk to you a little bit today about the initiatives that the organisation has got as a whole, and then 2 of the interventions that we've evaluated and we're moving to take forward to try and tackle unfairness within medical education and training. Now, my presentation will focus on trainee doctors. So in the UK, we have over 72,000 doctors in postgraduate training and 9,810 medical school placements. And the UK government has set targets to increase that by 2031 to 15,000. And there you can see on the screen the ethnicity and the makeup of trainees in postgraduate training, which is increasingly becoming more diverse with more international medical graduates than ever practicing in the UK. So as a whole, the General Medical Council has taken a lead in setting ambitious strategic targets, and these cross over 4 key domains. The second one is what I'm going to talk about today on education and training, but I will just touch briefly on the other ones. So the other targets include employer referrals, the referrals into fitness to practice investigations. There is disproportionality in ethnic minority doctors being referred into investigation by designated bodies. So there's a whole programme of work to try and reduce that with targets to create proportionality by 2026. Within the organisation ourselves of GMC inclusivity, we've got targets to increase fairness. So to eliminate differentials within our own staffing, performance, recruitment and representation, also looking at things like pay and progression. So our Human Resources Directorate and our Central ED&I team are leading this work with a whole host of groups of colleagues to try and address the unfairness within the systems and processes. And we've also got a piece of work called Regulatory Fairness, which covers across the whole organisation, looking at decision making from an ED&I lens. So are decisions that are being made fair? Are we going through robust processes? Are we consulting and considering the impact on different groups from an impact assessment when decisions are being made. But the one I'm leading, the program that I'm leading is on education and standards. And the target that we have is to eliminate discrimination, disadvantage, and unfairness in medical education and training based on ethnicity and place of primary medical qualification by 2031. So you may ask, okay, well, it's great having the ambition there, but how are you going to measure the targets? And the way that we measure the targets are through 5 key indicators, and we are looking to expand that into further indicators in the future. So we use postgraduate examination data. This is data provided to the General Medical Council by medical royal colleges across the UK. And our baseline data is 2019's data. So if we go back to 2019 and we look at the exam pass rates of UK white doctors compared to UK ethnic minority doctors, there's a 12% gap in attainment. If we look at UK doctors compared to international graduates, so doctors who hadn't qualified in a UK medical school, but in a medical school overseas, the gap in postgraduate examinations was about 29%. If we fast forward to 2022, we've put lots of initiatives in place, lots of interventions in place, been working with organisations to tackle the challenges. The gap between UK white graduates and UK ethnic minority graduates has reduced to 10%. It's a small reduction, but the trajectory is showing that there is a reduction in the gap. And for overseas graduates, the gap has reduced to 22%. So we can see that the gap is starting to narrow, and we're working with organisations to understand the interventions that work by evaluating them to see, well, what more can be put in place to reduce the gap and create more fairness. We also receive data from medical schools, and postgraduate training organisations. And again, for all these measures, the gap is starting to reduce. We do also have 2 indicators, which are in the lower boxes, one around inclusive environments and one around preparedness for foundation posts. The General Medical Council, we host a national training survey every year, and it is completed by around about over 75% of trainee doctors, and it's also completed by around just under 40% of educators. So every year we get feedback from about 72,000 doctors on the state of medical education and training, their own perceptions, their own experiences. It's a huge survey, and we use that to inform our work. In the previous presentations, we talked about risk-based approaches. So if we get any red flags from the survey, we inform that into our quality assurance processes and work with organisations to explore what can be done to address the challenges. But with regard to my project, we've got 2 questions here. One about inclusive environment. So we ask trainees, how do they feel? What is their perception about the inclusivity of their organisation? And the gap compared to 2019 to now has reduced. However, the one indicator that is going in the opposite direction to where we would like it to be is preparedness for first foundation post. So when a trainee leaves medical school and they go to their first foundation post, the statistics for all trainees, for all protected characteristics, is dropping. And we believe that's down to issues such as burnout, time for training, the backlog from the pandemic. We've published the state of medical education and training, which kind of covers some of the challenges and areas. So what can be done to address this particular area? We asked this at a conference very recently, and the key feedback from educators was about mentoring, relationships, time for training, again, are key areas that need to be kind of really worked and thought about to address this challenge. So in terms of the Fair Training Cultures Programme of Work, we've published and commissioned lots of research over the last few years. One was by Dr. Catherine Wolfe, which explores the barriers that trainees face in medical education and training. And one was about the success factors by the Work Psychology Group. This research explores the success factors for those trainees who had been successful in medical education and training. And from those pieces of research, we've developed a programme of work, which includes curricular and assessment, recruitment and selection, support for trainees, support for educators. And within these, there are approximately 20 separate pieces of action and work, which is being led within the organisation of the General Medical Council. But externally, the organisations that we regulate, they are also taking action. So to give you an example, in Scotland, the health regulator NES in Scotland, they also have 20 pieces of work, which range from developing international medical graduates inductions to mentoring schemes and feedback. So there is lots of action that is taking place to try and tackle and address these issues. The General Medical Councils over the last few years has been asking all those who we regulate to provide us with EDI, Equality, Diversity, Inclusion action plans. So we receive approximately between 30 and 40 action plans a year from medical royal colleges and from postgraduate training organisations. And we ask them, what are they doing in this field? What are they doing to address the issues of differential attainment and unfairness? And what we then do is work with organisations to try and understand what is in their action plans, what are they doing to address. We speak to trainees, we speak to educators, and what we then do is try to work with organisations to evaluate the impact of these interventions. So the two at the top of the screen today are the ones I'm going to talk about, but this just gives you a small snapshot of some of the interventions that are included and some of the themes that are included as part of the action plans. So the next one I'm just going to talk about is we collaborated with the Royal College of Psychiatrists and also NHS. The NHS in the Northwest, as well as Edge Hill University, which is a university again in the Northwest, to try and monitor and evaluate an intervention. So it's developing and monitoring and developing evaluations. This intervention focuses on examination preparation techniques, and what this intervention was focusing on was the OSCE style examination for psychiatrists, so the clinical examination for psychiatrists. It was a 2-day training course. It was developed by examiners, and it consists of exam techniques, mock assessment stations, feedback from examiners and from peers. 180 trainees attended this course across 8 cohorts. It was initially delivered to those who had failed the CASC, which is the examination, the clinical assessment. And then it was offered to ethnic minority trainees and trainees for overseas. So the final evaluation for this will be available in early 2024 when we've got the exam results for all trainees who've been through this intervention. But from 2 of the cohorts that we've now got exam outcomes for, we can see an 11.3 percentage point and a 12.9% increase in pass rates for those who have been on this assessment, this intervention, compared to those who didn't. So the early indications is that mock exams and formative feedback are a good indicator and a good intervention to help with success. On the back of this, the Academy of Medical Royal Colleges, which supports all medical royal colleges, have developed some guidance for all royal colleges on supporting trainees with examination preparation and in also giving and receiving feedback. So further action has been taken on the back of this, and we're also aware that other royal colleges are starting to develop interventions of this nature. So that intervention was one that focuses on trainees. The next one is educator training. So this intervention was developed by Professor Subodh Dave and Janet Ellison of Derbyshire Health Trust. And it is training on it's training for educators on giving and receiving feedback and having difficult conversations and understanding the impact of differential attainment on the trainee, the educator, and the system. The 129 educators attended 5 workshops, and what this focused on is what can be done to support trainees through training Some of the interventions that I talked about earlier, such as induction, feedback, mentoring schemes, etc. On the back of this intervention, the GMC is now developing educator training, which can be used more universal across all medical royal colleges. So in giving and receiving feedback, considerations, reverse mentoring, mentorships, those kind of interventions that could be considered as a toolkit that educators can use in developing relationships with trainees. So the GMC, we publish and we put this all our data in the public domain. You heard from Andy Napton yesterday, who I work very closely with. So he's developed a lot of data dashboards on education and standards. So we publish data on our website on exam, recruitment, and assessment data, all on our website, and you can split that by different protected characteristics. We commission and publish research, and we then use that data and that research to then build that into our standards and our policies. We've just published Good Medical Practice, which underpins the expectations and the duties of a doctor in the UK. That will come into effect in January 2024, but the lessons from fair training cultures has been embedded into our standards and our policies. What we then do is build that into our quality assurance processes. So we ask all the organisations we regulate to provide us with quality, diversity and inclusion action plans, but we will ask them specific questions based on the research. So we'll ask them questions, how are you assured that the diversity of your examiners and assessors, that they are diverse? What are you doing in the field of examination preparation, etc.? Once we've done the quality assurance, we then work with organisations to evaluate the work. And we've got a hub of resources on our website, which range from case studies to small videos, to all the research that we've commissioned and published. So I guess in terms of key messages from myself, and lessons learned, I would say utilize data and research when developing intervention, work to evaluate interventions when that's possible and build the evidence on impact, and collaboration between organizations is key to make system change of this nature. So that is a link to the GMC's differential attainment web pages, and that is the contact details for my team. So I look forward to answering any questions that you've got as part of the discussion.
Thanks, Stephen. Do we have our online panelist? Okay, that's great. So we have Faith Mitchell from Washington, D.C. joining us. So Faith.
Thank you, Abby. I'm going to share my screen now. So I hope everybody can see that. Okay. I'm going to pick up on some of the themes that Stephen mentioned. I think our presentations are very complementary, and talk about some studies that we did at the Urban Institute on diversifying the U.S. healthcare workforce. You'll hear me talking about training challenges and inclusive environments, but something I want to call your attention to that really struck me when Stephen was talking was that he was describing a government commitment to diversifying the workforce and improving outcomes for students of color. And of course, in the United States, we have no such government commitment. So any kinds of efforts to diversify the healthcare workforce take place at the institutional level. So that's and as you probably know in the audience, affirmative action was recently struck down by the U.S. Supreme Court, and there's a growing opposition to race-conscious policies. So we are still fighting an uphill battle in the U.S. when it comes to the issues that are being talked about on this panel. And I welcome your kind of comments and thoughts about that when we get to the Q&A period. So first, just a little bit about the Urban Institute. We are a nonprofit research organization in Washington, D.C. that was founded in 1968 by LBJ when he was president, and it was the Great Society period. And, the title of the organization kind of reflects the orientation. We do a lot of research on issues related to cities, and in particular to kind of Black and brown and low-income residents of those cities, providing data and evidence that we hope will help advance upward mobility and equity. And we are a national resource. States turn to us and the federal government as well in terms of these issues that we work on. So what we know is that a diverse healthcare workforce can help improve health. There are lots of studies that support that and that show that diversity in the healthcare workforce improves health equity overall. It results in more satisfied patients. There's better patient-clinician communication. There's hold on a second, access to high quality and culturally effective care, and that having a more diverse healthcare workforce can lead to, importantly, diverse representation in leadership, policymaking, and research. So we know that. There's been plenty of research to support that. But the problem is that the U.S. healthcare workforce lacks diversity. Whereas 30% of U.S. residents identify as Black or Latinx, only 12% of U.S. physicians identify as such. So most of my slides will focus on physicians, and occasionally you'll hear me talk about nurses too, and I hope I won't get muddy with that, and I'll be clear about that. American Indians, Alaska Natives, Native Hawaiians, and Pacific Islanders are also underrepresented. So we still have a predominantly white medical workforce in a country that is rapidly diversifying. So one of the studies I want to tell you about was called Improving and Expanding Programs to Support a Diverse Healthcare Workforce, Recommendations for Policy and Practice. We did it a year ago. And what we wanted to look at in that study was persistent barriers and challenges that face aspiring doctors and nurses from groups of people of color, using data from interviews and focus groups, which we held with dozens of students, professionals, and field leaders. And we looked at the role of what are sometimes called pathway or pipeline programs that recruit and support people from systematically excluded groups and try to bring them into the medical and nursing professions and then place them in positions. And we developed recommendations for the federal government, state government, leaders at higher education and health system institutions, and philanthropy. And what we found basically that is, just as Stephen described, pathway programs are instrumental in increasing the diversity of the health professional workforce. Effective programs, and we identified qualities of effective programs. For instance, academic support, which can come in a lot of different forms. I won't read all the different examples, but summer programs, exam prep, the way Stefan described, study tips, and so forth. Financial support can be a part of these programs and is important in the form of scholarships and tuition waivers and so forth. There's the social element, mentorship, which I'll be coming back to, providing students with affinity groups and activities. There's an institutional element of these programs, which has to do with their commitment to diversity, equity, and inclusion. And then there's the sustainability and accountability element, which is making sure that programs have the support they need to build capacity and to be sustained, through the period that students are involved, and even longer than that. And as I mentioned, because we're not talking about any kind of government targets, when we talk about sustainability or commitment, it really is just at the institutional level in the US. Then a second study that we did was understanding training in workforce pathways to develop and retain Black maternal health clinicians in California. So that one was posited on our knowledge that Black birthing people have bad outcomes, infant mortality and maternal mortality, and many times the rate of non-Black birthing people. And so this study was funded by a foundation that said perhaps one way to address that problem was to have a more diverse birthing workforce. And so we looked specifically in California, but with implications for the rest of the country. And so again, we were looking as our initial problem with the fact that the healthcare workforce has not made significant progress toward increasing and sustaining the number of Black maternal health clinicians. So we looked at opportunities for and barriers to increasing the workforce of Black OBGYNs, labor and delivery nurses, and midwives. And we conducted in-depth interviews in California and also nationally with Black maternal health care clinicians who represented different fields of practice. And then we also did a review of the literature. So some of the challenges that we found that Black healthcare clinicians faced multiple challenges during training. And those trainings included the high costs of attaining professional degrees, racial bias in the medical and nursing school admissions process, the fact that once in training, Black students were more likely to report experiencing racism and discrimination. Black students were also more likely than their non-Black counterparts to carry over high debt from medical school once they were in practice, and to encounter race-related stressors at work that contributed to higher levels of burnout and attrition. And once in practice, and this contributes to burnout, we found that Black professionals earned less than their colleagues who treat fewer. They were more likely to settle in Black communities. They were more likely to earn less than their colleagues who treated fewer patients from ethnic minority communities. And they had fewer patients who were covered by Medicaid, which is the government program, meaning they were covering more people who were uninsured. And so having to kind of eat those financial losses. So, you put that picture together and you have a stressful training process and then additional stresses once people were in practice. Our recommendations coming out of that report were that financial support be offered to Black maternal health trainees and clinicians. Some of that support is provided by government programs, but a lot of it in the United States comes from foundations or ideally state programs. We also recommended the development of additional training and support programs because there aren't enough to meet the need. The removal of barriers to Black midwives' entrance into and retention and practice. With Black midwives in particular, we found that they often don't have access to training programs in their states. They would have to participate in training programs that were like across state lines, which can be expensive. They also ran into barriers in terms of the practicum that is part of the training, not being able to find other Black midwives to work with, and white midwives sometimes being reluctant to work with Black midwives. We also need to address the need for maternal health workforce diversity in hospital settings, meaning hospitals need to take responsibility for diversifying their workforces. And finally, that our studies focused on people who were in training already, so they were like in college or in medical school or in nursing school, but really we learned, and shouldn't be a surprise, that if you want to diversify the healthcare workforce, you have to start at much younger ages, and that there was a need for recruitment for Black, and I would say also Latinx students and other underrepresented groups at the primary and secondary levels. If you wait until people are in college, you've already lost a lot of potential providers. The last point that I want, to make is that we also felt that workforce diversity is just part of the larger solution, and that while on the one hand we need to be recruiting and retaining more practitioners of color, we shouldn't have the idea that white practitioners cannot adequately serve patients of color. This gets to the point Stephen made about he called it building fair training cultures into core work. In other words, we can't wait until we have enough numbers of Latinx and African-American health professionals to say now we have adequate care for patients of color. We need to make sure that white practitioners can also provide appropriate and culturally sensitive care. And so embedding healthcare equity and healthcare education is absolutely critical, and it needs to accompany the diversification of the workforce. And I didn't put links in the slides, but I can send the links to those two studies to Sheena afterwards, and perhaps she can distribute them later or make them available.
Thanks, Faith. That was really helpful. So next we have Professor Bukola Salami.
I today will be talking much more closely about the Black health workforce in Canada, from both talking from an historical perspective and also the current day realities of Black health professionals in Canada and what we've seen happen, especially over the last 3 years following the George Floyd murder and what has happened with the Black workforce in Canada. So I'd like to acknowledge before I start and pay tribute that I am currently located in Treaty 7 in Southern Alberta. And this territory includes the Blackfoot Confederacy, including the Siksika, the Piikani, and the Kainai First Nation and Tsuut'ina First Nation, and the Stoney Nakoda, including the Chiniki, Biaspor, Goodstoney First Nation. The city of Calgary is also home to Métis Nation of Alberta, and on this land, in this place, I strive to learn together, work together, and grow together with Indigenous people and other. And I also want to reaffirm my commitment to work in parallel path for to achieve health outcomes for Indigenous populations. So in Canada, contrary to popular opinion, we have a deep history of racism. And some of the histories that we have regarding racism includes Indian residential school, unethical research practices with Indigenous people, including being exposed to malnutrition and dying of Indigenous children in residential school. Forced sterilization of Indigenous people. We have slavery. Oftentimes people think slavery is just a US thing, but we did have slaves in Canada, both Indigenous and Black slaves. We had a history of racist immigration policy, and we've also had other histories related to racism of Chinese, South Asian, and also Japanese population in our history. So I'd like to highlight here a policy that we had in Canada between 1910 and 1967. This policy was removed in 1967. So the policy prohibited for a stated period or permanently the landing in Canada or the landing at any specified point of entry of immigrants belonging to any race deemed unsuitable to the climate or requirements of Canada, of immigrants of any specified class, occupation, or character. And this was mainly meant to try as much as possible to deter Black people, especially those coming from the US, from being able to migrate to Canada. And it was used sometimes to deny people that were non-white from being able to come to Canada. And just in case Black people didn't know that, we don't want you here, it was recommended in Parliament that the Negro race is deemed unsuitable to the climate and requirement of Canada. I must say that the other in council was not approved, the last one on Negro race, but we still had the piece that people unsuitable for the climate and requirement of Canada could be banned from coming to Canada just based on your color of your skin. In 2018 or 17, the United Nations Working Group of Experts on People of African Descent came to Canada, and they did consultations with Black communities and did some interviews. And what they concluded in their report, in the UN report, is Canada's history of enslavement, racial segregation, and marginalization of African Canadians has left a legacy of anti-Black racism and a deleterious impact on people of African descent, which must be addressed in partnerships with Black communities. So what started in 2017 was a series of initiatives by the federal government in 2018 to correct this wrong. So we had $15 million, I believe, in funding allocated in the 2018 federal budget to addressing some of the needs of Black communities. The Public Health Agency of Canada had about 7 million, 9 million of that, and the Heritage Canada had about 7 million or so of that. And for the Public Health Agency of Canada, what was created is a Black mental health initiative in Canada to address the mental health of Black populations in Canada, with funding to Black community organizations. Heritage Canada sort of had a different framework, and there was different initiatives related to social and economic outcomes for Black people. In terms of history, we have history of racism in the health workforce. So for example, this is right from Queen's University website. Black people were often banned or not prevented from being able to get into med school. So we had in 1918 a motion to ban students of African descent from the School of Medicine at Queen's University. Although Black students started getting admitted, starting in 1965, I think it was only in 2018 that the ban was actually officially lifted from the university policy book. We also have history of racism of Black people in Black nurses in Canada. So a lot of the early Black nurses that we had in Canada was from the US. And there was a reason for that, because no school in Canada was Black nurses into the profession. So, I think the early Black nurses we had were probably around 1950s, 1940s. And they were initially trained in the US, which were the schools that will accept them. I think the lady down is a teacher, was a teacher or principal. I think she retired maybe around 20 years ago. And she was a very brilliant Black woman that had tried to get into nursing school in Canada and was denied from getting into nursing school. She ended up going into education, and she retired as one of the first principals, Black principals in the educational sector in British Columbia. So in Canada, we have the cappuccino effect. And I say this, someone once told me that the workforce is like a cappuccino. It's Black underneath and it's white on top. And, sometimes you sprinkle a little bit of Black on top to create an illusion that it's diverse. And this has implications. It has implications in terms of health workforce. So we saw this during the days of COVID-19 pandemic, that we had a higher rate. We had Black people had a higher mortality rate in 2020. And some of the reasons for this is because we are concentrated at the bottom of the workforce, which means that, for example, we had more personal support workers, more bedside nurses that we are Black, and less in leadership positions. And what that means is that we were also having more contact with patients. And that contributed to a higher rate. And of course, the other piece that contributed to a higher rate is low COVID-19 vaccination rate among Black people, which was situated on historical grounds, including historical injustices related to that contributes to mistrust within the population. Some of the experiences of Black people in the workforce includes issues related to racism in the workforce, and also racism in clinical practice for healthcare professionals getting their clinical practice. Microaggression underrepresentation in leadership position and lack of career mobility and promotion to leadership position, lack of mentorship. And, lack of mentorship, the historical piece really can help us understand the lack of mentorship. Because when you historically have difficulties of Black people to be able to actually get to leadership position, there's not a lot of Black people that can actually mentor other Black people to be able to get to those highest level positions. And oftentimes white people will normally mentor other white people. And that has implications in our mentorship. It has implications in us being able to get to leadership position. And also the few that do get into leadership position also face the piece about minority task. So being, of course, automatically deemed the EDI person. And EDI, you do a lot of EDI work, but you don't often get a lot of credit for that work. And also inappropriate curriculum content. So some of the trends we have, and many of the trends we have as, started in 2020 in response, and in response to the Black Lives Matter movement, there were several initiatives that got started in Canada. One of those is increasing number of Black health organizations in Canada. Before 2023, 2020, I would think that the only Black health organizations we have in Canada was, I think, there's a Black organization in Nova Scotia, Black Health Alliance, Taibu Community Health Center, Black Physicians of Ontario, and I think there's a Black Social Workers. Now we probably have, more than 20, 30 Black health organizations that I can count in Canada, and it has implications. And the other program that was started is increasing number of Black admissions process at medical schools. So medical schools now increasingly, many of the medical schools we have in Canada have a Black admissions pathway in Canada where Black students can submit the application, oftentimes have the application assessed by people that are much more culturally competent. Oftentimes, many are Black professionals. This has increased in many medical schools, the number of Black people in medical schools. So for example, I believe at some point at University of Toronto, maybe there was maybe 1 or 3 Black students admitted to university every year. And I believe a year ago or 2 years ago, there was maybe around 25, 26 admitted to one medical school, to one of the leading medical schools that we are Black. The University of Toronto recently created a Master's in Public Health with a focus on Black people's health, which is the first Black-focused health degree in Canada. I am co-chairing a best practice guideline on addressing anti-Black racism in Canada, which is a best practice guideline of the Registered Nurses Association of Ontario, and that will be released next year. We also have several committees that have been set up to address racism. And the CASN one, that's a mistake. It's not anti-Black racism. It's anti-racism working group. So there's a Canadian Nurses Association anti-racism group. There's a Canadian Association of Schools of Nursing anti-racism working group too. We've also increasingly had in Canada targeted hiring of Black people in universities. So we have several universities that have implemented targeted hiring. Of course, increases dramatically the number of Black people. So the hiring is one thing, but also, how are you positioning those hires for success is one other thing. Funding prioritizing Black people has also increased. So, some of those are RBC for racialized Black. In the 2021 budget, I believe there was about $1.2 billion that was allocated, not to Black people, to Black, that prioritized funding for Black and Indigenous and racialized populations. Now, that is the prioritized funding. That did not, there's no evaluation on actually who ended up getting that, if it was actually Black people. But that said, we will prioritize funding for this, for Black population. And we also have a recently Canadian Institute of Health Research had a training award that was for Black people and also racialized women. So for you to get that funding, you must either be racialized women or a Black man or woman. And I know the CPSA has had some discussions related to upgrading their entry into practice. I forgot what they call it, professional competencies for physicians in the area of professionalism to integrate much more anti-racism into it. And the Canadian Nurses Association is currently in discussions related to upgrading its code of ethics to include anti-racism as a component of its code of ethics. And we've had several health professional organizations do curriculum revisions. So those are some of the trends, and what are some of the challenges that we face? One of the things that we have is that we have a lot of siloed initiatives. So we do not have a national strategy or national plan for addressing racism in Canada, or for addressing in health workforce in Canada, or a national strategy for addressing anti-Black racism in Canada. We just don't have it. The other one is equitable collaborations and partnerships. So what we've had is we've had a lot of growth of many Black organizations in Canada, Black health organizations, professional organizations, service provider organizations in Canada. What we do not have is establishment of equitable partnerships between the smaller organizations and the bigger organization, including to build capacity of those organizations and leverage them for maximum impact. And issues related to, of course, the limited leadership. So what we have is we've had people provided with opportunities to get into the workforce. What we've not addressed is get up in the workforce. So we still see so we have physicians coming in, but are they actually becoming leaders in their fields? Or nurses coming in, are they becoming leaders in their field? Issues related to sustainability has been of this initiative. So what we had is in the early days of the George Floyd murder, we had all these initiatives. And it seems at this time we are beginning to have a sort of a downward trend or spiral in terms of interest in continuing on with some of the initiatives that got started and a commitment to equity, diversity, and inclusion. Evaluation is a challenge. So of all the initiatives I have told you, rarely do we have any initiatives that have been evaluated before. And that's a challenge. So for example, we do not know the Black, students going in, what is their success rate at medical school? What is, what professions are they choosing after medical school? And, where are they landing in terms of their upward mobility? We do not know. And to what extent is this also because closing the gap in terms of health outcomes for Black people. So the links between health, Black health, Black health initiatives and health outcomes of Black people has not been well established. And also accountability. So in many of our standards of practice, and this is my thing, we do not have racism as a standards of practice, as a code of ethics, as a competence for many healthcare professions in Canada. And what that often means is that we can throw in money into different things, but oftentimes when people are not held accountable, and when leaders are not held accountable, or anti-racism is not a competence in terms of what a leader must deliver, then that actually creates gap. And I think I already said standards of practice and code of ethics in Canada often exclude racism. And sorry if I didn't time my presentation, so I don't know how long that was. Thank you.
No, thank you. That was very nicely done and a great presentation. Thank you, Dr. Salami. So our final presenter is Jayde Fuller from Australia, who's joining us by video.
Hi, everyone. I'd like to acknowledge the ongoing sovereignty of the Quandamooka and the Turrbal people, whose sacred land I'm privileged to be speaking to you from today. I recognise the strength and power of First Nations ways of knowing, being and doing as a critical, protective and enabling factor for combating racism in healthcare. I'd also like to acknowledge the collective expertise of any other First Nations people joining us at this conference. So I'm Jayde Fuller, and I'm an Aboriginal woman from the Gamilaroi Nation and the National Director of the Aboriginal and Torres Strait Islander Health Strategy Unit at the Australian Health Practitioner Regulation Agency, or Ahpra for short. I'm sorry I couldn't be there in person today. I'm going to share with you some of the initiatives and key principles that we've adopted to regulate against racism and for the cultural safety of Aboriginal and Torres Strait Islander people receiving healthcare and for Indigenous practitioners in the workforce subject to racism. Please note these principles and ways of working may be transferable to other health workforce bodies wanting to work with First Nations peoples in their countries, but must be driven and supported and integrated by the local Indigenous leaders. So to give you some Australian context, the total Indigenous population accounts for 3.8%, just under 1 million people, drawn from 500 separate nations within different languages and histories. There are two distinctly separate First Nations groups in Australia: Aboriginal people who inhabit the mainland and Torres Strait Islander people who are custodians of the chain of islands in the Torres Strait region, which is positioned between the state of Queensland, so up the top of Australia, and Papua New Guinea. Australia's been home to Aboriginal and Torres Strait Islander people for 65,000 years, so one of the longest continuing cultures in the world. The country was colonised by the English 253 years ago. As Indigenous people, we experienced two forms of racism: anti-Black and anti-Indigenous racism. Given its recency, it's important that I raise the referendum result in Australia. So on October the 14th, we had a referendum seeking to establish an Indigenous voice to Parliament to be enshrined into our Constitution. So a mechanism that would allow Indigenous people to advise the government on matters that affect us. 60% of Australians voted against this. And the state that I reside in Queensland, had the highest no vote of all the states and territories in the country, resulting in a resounding message to Aboriginal and Torres Strait Islander people that we are not viewed by the majority of Australians as valuable citizens who should be able to have a say over decisions that impact our lives. Faced with these results, how could one not accept that Australia is indeed a racist country? Racism is inherently about power within society, wielded collectively by those who have it against those who don't. This slide gives you a chronological overview of when and how our cultural safety and anti-racism effort has been targeted over the last 6 years. In the interest of time, I'm going to share with you what I believe to be the 6 key success factors to our approach in regulating against racism in healthcare and the workforce in Australia. Self-determined governance models. So to work respectfully and safely with Indigenous people, governance must be grounded in principles of self-determination, centering our leadership in defining and driving cultural safety. We have the Aboriginal and Torres Strait Islander Health Strategy Group, our most senior authorising body relating to cultural safety program of work, a strategic body comprised of 15 health experts, both Indigenous and non-Indigenous members. It adopts a partnership model with an Indigenous health practitioner collective. It meets once or twice a year and is instrumental in shaping our strategic direction in relation to our shared goals. The second thing is Black expertise. So anti-racism and cultural safety reform requires Black expertise, a shorthand word that I use for Black expertise. We have Indigenous staff who are employed in the agency to lead and implement the cultural safety strategy. So the Aboriginal and Torres Strait Islander Health Strategy Unit, bit of a mouthful, or HSU as we call it for short, is 100% Indigenous staffed. We also recognise the value of having Indigenous people, both practitioner and community members, on our boards and our accreditation committees to impart their ways of being, knowing and doing into regulatory business. Ahpra's also recognised the great value of hiring external Indigenous consultants who have specific knowledges to develop and produce deliverables from design to strategic policy development and cultural safety training. The third one is a common definition of cultural safety. So in 2019, we held a 6-week public consultation process to determine a scheme-wide, and when I say scheme, I mean the agency, the boards and the accreditation bodies as a collective, definition of cultural safety. And it was decided upon by Indigenous members of the strategy group and the National Health Leadership Forum, which is that Indigenous practitioner collective I was talking about earlier. So having one definition has helped to form a common understanding and shared language amongst health practitioners' codes of conduct, their accreditation and their registration standards. Fourthly, strategising for shared goals. So as Indigenous people, we are always strategising for survival. It's a constant requirement for us. It's not healthy or good for our well-being, but we don't have a choice. So to keep the agenda of eliminating racism alive, we regularly gather collectively with board and committee members and with the Indigenous health practitioner peak bodies as well. We have dedicated working groups that are predominantly Black, and we convene to strategise how we need to move within the regulatory institution to achieve our shared commitment. So we hold each other to account and we draw strength from one another as collectivist peoples. Not only do we create and hold space for one another to do this important work, we work very closely with non-Indigenous allies who are committed to anti-racism and cultural safety. As leading authorisers in this space, it's critical that they work alongside us. The fifth factor is sharing power. Allies sharing power with us. They show up to the work with humility and actively use their power to give us what we need to deliver in this space. Allies leaning into their discomfort, being willing to engage in difficult conversations, and building that mutual trust and strong relationships with us underpins all of this work to date. And finally, legislative amendments. So in October last year, we saw the introduction of legislative amendments informed by the strategy group prioritising cultural safety in healthcare provision. It's the first time the word racism has been featured in healthcare legislation in Australia. In the last few weeks, we've had a landmark tribunal decision on anti-Indigenous racism made in the medical profession, resulting in a non-Indigenous doctor's behaviour being constituted as professional misconduct. He was prohibited from providing any health service and cannot apply for registration for at least 12 months. And I say landmark as it's the first case since the national law amendments were made last year, which includes a guiding principle that contributes to the elimination of racism. A racially offensive email was sent to Professor Rala Baker, who you can see pictured here, a highly respected Yagara, Warrangu and Wiradjuri ophthalmologist. The tribunal found that he was treated less favourably than other persons because of his racial background, which had an emotional effect on him. This conduct is unbecoming of a medical practitioner and, in the tribunal's view, had the potential to bring the medical profession into disrepute. The chair of the National Medical Board of Australia, Dr. Anne Tonkin, said, "This ruling is a clear message that racist and culturally unsafe practice and behaviour is unlawful and carries substantive penalties, including disqualification from registration." This ruling also reinforces the data in the medical training survey that we have, specifically the racism experienced by Indigenous doctors. Last year's survey found that 55% of Aboriginal and Torres Strait Islander trainees had experienced or witnessed bullying, discrimination and harassment, including racism, compared to 34% of all trainees nationally. You can read more detail on this outcome and the survey on our website. A few more key reform initiatives I wanted to discuss before I close today is, importantly, the development of an anti-racism policy. So we need to walk the talk as a regulator. We engaged Aboriginal race scholar Professor Yin Paradies to write an anti-racism policy for Aboriginal and Torres Strait Islander people in the workplace as the regulator, or accessing, so trying to access our services in the national scheme. So Professor Paradies understands the operations of race within institutions and how to address this using specialised expertise and lived experience, co-designing with us as Indigenous people within the scheme. This is a real opportunity to shape a policy that centres our lived experience, is responsive, it doesn't minimise the impact of racism upon us, and provides solutions that we deem appropriate. This policy should be published on our website in the coming months. Mung Mung Gat cultural safety training. So importantly, between 2021 and 2022, Mung Mung Gak, which means safe or secure in Wurundjeri language, cultural safety training was delivered by PricewaterhouseCoopers Indigenous Consulting across 1,596 staff, board and committee members, a first from healthcare regulators globally. And finally, the Culturally Safe Notifications project. This project is guided by a working group of majority Indigenous people to reform the cultural safety of our complaints processes, specifically those which relate to Indigenous health consumers and practitioners. The group advocated for the establishment of the Indigenous Medical National Special Issues Committee, or INSIC, which sounds very much like a very popular 90s boy band group, which is a delegated committee of the medical board, comprised of 50% Indigenous membership and 50% non-Indigenous membership, with a co-chairing arrangement. They will decide on complaints and compliance matters involving Indigenous practitioners or consumers. We did request majority Indigenous membership. However, due to legal advice received around perception of bias, having too many Indigenous people deciding on matters involving non-Indigenous doctors could result in increased legal action. A hard pill to swallow, given decisions have been made both in regulation and outside of it about things that impact us our entire lives by non-Indigenous people, and that's rarely, if ever, perceived as problematic. It's normalised. The Nursing and Midwifery Board, however, supported a terms of reference to have one Indigenous chair only and a majority Indigenous membership. So it's important to accept that racism exists in healthcare and in the workforce, and that it kills Indigenous people. And as regulators, we are often involved in the process when this occurs. I hope that this has given you some insights into our strategising and commitment to prioritising cultural safety and eliminating racism in healthcare through regulation in Australia. You can find out more about this work or reach out to us directly on the email on the slide by following our dedicated work page via the barcode on screen. Thank you.
We had amazing line of speakers, and I believe there's a question on the chat. So start with that and then open it up for the floor. So the first question is, we heard about.
If you want, Abby, I have them a little bit larger in front
yes,
of me here.
please.
Yeah, so there were a couple. So first of all, someone from the online audience just mentioned, probably mostly for Faith, that there are additional programs to increase health workforce diversity. The US federal government, through the Bureau of Health Workforce, has programs like the Centers of Excellence program and the Health Career Opportunities program. So that was just by way of addition, and maybe Faith, that you might like to speak to that. And then I'll also just post for Stephen. Examination preparation is fine and helps. We still observe in Canada, and this is from our colleague from Quebec, Andre Garapi. So he says, we still observe in Canada a systematic and significantly lower success rate of foreign trained candidates. Beyond the easy conclusion that those who have failed are not to the level, are exams not adapted to foreign trained candidates, especially if they are mature professionals? Is language proficiency an issue, and situational judgment that builds on soft skills? So maybe we'll pose those to Faith and Stephen, and there are some additional questions. There may be some here in the audience for Bukola.
Shall I go first?
Yes, please.
Okay, thanks. Yes, it's true. I didn't talk about the federal Health and Human Services Administration, for sure, in the United States, has a number of really important training programs in medicine and nursing. But I think the contrast that I was trying to make with the situation that we heard about in the UK or even in Australia is that there isn't an overall federal government commitment to diversifying the healthcare workforce that you see, like the one that Stephen described. There aren't targets. And in fact, it's an atmosphere now of opposition to that kind of approach. So the support that's there through HHS is, as I said, it's vitally important. It is augmented by support from foundations in many states. And so it's like a collection of initiatives that we have rather than a single one.
Thanks, Faith. Stephen.
Yeah, I'll pick up the second question about examinations. So we get the challenge all the time about the fairness of examinations, in particular for overseas graduates. And what we found that many of the Royal Colleges are now doing is to do a systematic review of the language used in examination and assessment to try and eliminate any bias or discrimination that may exist within those. The General Medical Council are working with organisations to develop a 5-year strategy, which is looking at exams, assessments and fairness in the future. So we're looking at the whole process of how exams work, in particular after the pandemic, where many derogations came into place where examinations didn't take place and clinical assessments or clinical skills needed to be assessed for trainees to progress because examinations didn't take in the same way. And Newcastle University in the UK has recently conducted a piece of evaluation on that, which we're looking to see early next year. So I guess the answer to the question is that we do get challenged on this all the time. Organisations are looking at fairness within exams and assessment to try and eliminate bias and discrimination, and we'll continuously review this. On another side, we're currently working with an organisation within the NHS, which looks at recruitment and selection of trainees. And again, just looking at the application process, looking at the questions and the guidance, the applicant's guidance to try and ensure that bias and discrimination is removed. So there's a whole host of activity taking place to try and address this.
Thank you, Stephen. So let's open it up for the room. Any questions from here? Yes, please.
Hello?
Yes.
Oh, yeah, there we go. Okay. This is a question for Bukola. Thank you for highlighting the racism that exists, continues to exist in Canada. I wanted to hear your thoughts about when people are recruited into positions because of history of discrimination. So Black people, for example, and wanting to get them into leadership positions. I've heard from colleagues that there's a perception of being tokenized, and that they are selected because they are Black. And it's this push and pull of like, we're trying to get these people into these positions because they have been discriminated and disadvantaged historically and currently, but they still feel othered and still feel like they don't belong. Just wondering your thoughts about that.
Thank you very much for that. And I think, yes, you're right, because what we tend to have is, we try to get one person to be able to show, and we take a lot of pictures. We take a lot of pictures to be able to proclaim, but then, our actions are not genuine. I think, one of the things that we need to think about is when we do get people into the position, are we getting one? Or are we actually trying to achieve equity? Because what tends to happen, including a lot of the cohort hires that we have at universities, is once one Black person gets into a faculty, the door closes for any other Black person to be able to get in. That's what we tend to do. So knowing that, it is not one, it is actually ensuring that, the Black population represents the diversity of the city or the location that, or the province that we are looking at. The other thing that we have to think about is the support that whoever is in the position receives. Because what happens also is when a Black person gets into a department, then every Black problem, they have to deal with it. Every problem, it's like, yes, you're the one that caused this, right? And you have to deal with it. And that has implications. It has implications also in terms of upward mobility. Because, for example, I'm just thinking about a faculty position. If all the Black students that have problems and challenges, including experience of racism, start coming to me, it probably has implications for how much papers I'm actually able to publish and how far I can get into. So this is some of the challenges that we have, is in terms of the support that we have, and also not just in terms of support, the reward that we are getting for some of the, there is a lot of hidden work that minorities do just by being in a position or being a first in something. First in your department, first at your institution, first person to get into leadership position. And those hidden work are often not acknowledged, not considered, and there are no measures in place to actually address those hidden work. So I think that's some of the things that we have to, and also ensuring that it is not, I've been on some tables in the past that I feel like, when there's an issue, not about Black people, any issue about racism and diversity, and everyone is just looking at me and I'm like, I am not a solution to all your problems. So that's some of the challenges we have to address.
Yeah, Bukola, that's really nicely put, because there's a gap between the check boxes and policies and actual culture in the organizations and how it gets implemented. I know Faith has a point towards the same question, so I'll ask Faith to comment.
Okay, unmute. Thank you. Bukola had mentioned, as a question for her and also for Stephen, Bukola had mentioned accountability and evaluation. And one point I wanted to make was just that in the US, just as you described in Canada, Bukola, we have very poor statistics about the diversity of the workforce at a national level. There are like some different projects of people who are trying to track that. But when we did our project in California a couple of months ago, even for just California, it was very difficult, one huge state, to get statistics of like who's recruited, who stays in these pathway programs, and then what happens to them, where do they go, and how many of them kind of stay in medical or nursing professions, and how many drop out. So I just want to underscore, when you mention that we really need better numbers. And my question was, in the US now, in addition to that problem, there's more interest in tracking health outcomes by race and ethnicity, big push for data collection by hospitals and insurers and so forth. And I wondered if that's happening in the UK and Canada.
Stephen?
Yeah. So I guess in answer to that question, it happened in particular after the pandemic, and the statistics of different ethnic minorities and backgrounds of the impact of the pandemic. So I guess in answer to your question, absolutely yes, that data is now being collected. I do feel quite fortunate in the UK in particular of speaking, because we've got data gurus such as Andy Napton who talked yesterday. So we're in a really fortunate position because we've got a single employer, we get data from Royal Colleges, and we get data from medical schools, and we're the central hub as the regulator to collect all that information. So we're in a very fortunate position to have the data to inform our policy making and decisions.
Thank you, Bukola.
For me, I think before 2022, there was really any race-based disaggregated data on Black and racialized population. We had some data related to immigrant population. The Canadian Community Health Survey does have question about race, and the Canadian Health Measure Survey. So we have some national data sets that have questions about race. Some of the challenges we have is the sample of Black and racialized people of different categories collected in some of those makes it very, very difficult to be able to actually do a sub-analysis. In terms of our workforce, many of our analysis we are not able to do because we did not collect, at least before 2020, we were not, I think as far as I'm aware, in any hospital in Canada, collecting any data related to race, either race of patients, race of professionals. There was nothing. So I think it was after 2020 that then there became increasing calls in terms of the need to collect race-based data. And it's possible that maybe there's one province that maybe doing it now, or two provinces. But in Canada, generally, the vast majority of provinces we have in Canada do not collect data on race. During the COVID-19 pandemic, a lot of the data that we had on race during the COVID pandemic, the initial data that we had on race in the COVID-19 pandemic was not as much about the race of participants, of people, but more of the representation of Black people in a certain neighborhood. So we were finding that in neighborhoods that had significantly more Black people, then we had more people we had more people that we are having COVID-19. So the collection of race-based data in Canada, I should tell you, Faith, that a lot of times we look at, a lot of the data that we provide for Black people here in Canada, we actually use data from the US and say, based on, a lot of our literature reviews are always from the US. We are very, very poor in Canada on our collection of race-based data, including on health outcomes, health service use, and so on and so forth.
Thanks, Bukola. Ivy?
Yes, there are two questions online, and I also just want to give a little plug for the conversation that we had yesterday about the importance of data standards, including data on equity, diversity, inclusion, that being very important. And that feeds into, Faith, what you were saying about the importance of accountability and evaluation. If you don't have any numbers to say that, then you won't be able to say. So two issues. Number one, and you guys can decide which you want to take in whole or in part. Number one is Jayde had mentioned an issue around a strategy group and the importance of a strategy, and you raised that issue as well, Bukola. And Faith, your comments about, these are different little projects, but there's not sort of a joined upness about that. And one of our anonymous attendees also noted that yesterday, Marilee, who presented on behalf of Canada, talked about a 500-year plan, right? Not a 5-year strategic plan, but a 500-year plan. So that's one kind of cluster of issues around strategies moving forward. And then the second one was the notion of cultural safety, or sometimes what we refer to as cultural humility in Canada, the role of that training. Jayde had mentioned that in her closing comments. And one of the folks online had said that there's some debate within the Canadian medical space about how EDI should be considered just as important as other forms of medical competency and training. So curious about your thoughts about the importance of competency and cultural safety, humility, and strategy going forward. So over to you, whoever would like to go first. Stephen?
Yeah, happy to take the strategy. Well, I think we've been working on a strategy for many years. So for many years, the program of work was differential attainment, and it was building the evidence base with using data and research. And that has now informed our policy and decision thinking to develop the wider strategy. And the strategy now which has been set by the General Medical Council Chief Executive Board, which includes internal and external members, is that we will have eliminated disadvantage and unfairness by 2031. So I know the talk yesterday was a 500-year strategy, but what this strategy is the current index measures of exams, medical school data, and the data that we get from our national training survey. We attended council recently, GMC Council very recently, to talk about beyond that, because obviously a commitment has been made to 2031, and there's complete acceptance that this work will continue with new measures, new data, new questions. We've recently asked about anti-discrimination questions or discriminatory questions and sexual behaviour as part of our strategy. And we know our focus on our strategy at the moment is ethnicity in place of primary medical qualification, but there are other protected characteristics where there is disadvantageous and fairness. So we know we need to expand our scope of work into other pieces. So we do have the strategy which is focused on ethnicity and primary medical qualification at the moment, and we'll be moving into other protected characteristics in the future. And we've just published a new piece of research which we'll publish in 2024, which is looking at all protected characteristics, socioeconomic factors, which includes somebody's postcode, where they live, and socioeconomic factors, and the predictors of passing exams, looking at all intersectionality, and we'll be able to model that, which will inform our strategic thinking moving forward.
Faith, Bukola, any comments from you?
Yeah, I can comment.
Yeah.
I had to smile a bit when you mentioned, I think it was the concept of cultural safety, in the sense that 50 years ago, that's what got me interested in medical anthropology, was hearing about an anthropologist who was working in a hospital in Miami, trying to improve the interface between a very diverse group of people who were coming in for medical care and 50 years ago, for sure, mostly white doctors. We've made progress since then, but it's taken a long time. And I think medicine took a long time to understand what the social sciences got a lot sooner, meaning that people do better when they feel safe and heard, and acknowledged in the medical encounter. So it's still very important in the United States. You have people of different immigration status, people who speak different languages. You have differences in terms of racial and ethnic identity. You have sexual orientation and gender identity. I mean, all of these different, qualities that people bring to their encounter with a physician or a, nurse or whomever. And as I said, I think reluctantly, medicine and nursing has come to understand that you have to meet people where they are. You can't treat people as though they are just, one type of person. And so that training, which is also getting pushback in the United States, but that training is really important, and it's not perfect. We had a presentation at the Urban Institute a few months ago by David Williams. Some of you may know that name, from Harvard, who's, a sociologist and a sort of pioneer in talking about diversity, equity, and inclusion. And he said, you know, it's kind of mixed reviews in terms of what we call diversity training in the US. Sometimes it's helped, it's led to better outcomes. Sometimes it hasn't. But I think we have to stay committed to it and to improving these programs and learning from international examples. I mean, I've learned a lot just from this conversation this morning. And as for 500-year strategy, I'd say we don't have that long to wait. I mean, no.
Thanks, Faith. Bukola, do you have anything to add here?
Yes, and I am not sure. Hopefully, I will be answering the question. I'm not sure if I'm directly or indirectly answering the question, but I remember, you know, around 2019, I was an interprofessional educator at a hospital in Toronto, and I was teaching about cultural competence. And, you know, in the early days when I was in nursing school, we used to be told, you know, this is the way Latino people behave, this is the way Black people behave, this is the way, you know, different. And I think now we understand better in terms of how we homogenize people and how that in itself can be anti-racist. What we've had in Canada is a multiculturalism policy in Canada. And I think in Canada, because of our multiculturalism policy, we often focus on culture at the expense of racism. And what do I mean by that? Because oftentimes we say, oh, you know, it's because of your culture. So it leads to victim blaming sometimes when you focus only on culture without actually focusing on the embedded systemic racism within the system, which then shifts the blame. So I think in terms of EDI, sometimes we glorify EDI without actually doing anything about it. But I must say, EDI to some extent and equity, diversity, and inclusion initiatives has moved us forward in some realms. So for example, we can think about the Canada Research Chairs, for example. When it was first created, it was a chair position, an advancement position for white men. And EDI, of course, got us to have more first white women, and then got us to have more ethnically diverse population. And we are more slower, though, in terms of getting people with disabilities on board in terms of that. So while EDI does move us forward, I think, you know, there has been advocacy, including advocacy by Indigenous communities, in terms of the ways in which EDI may also sometimes be exclusionary or not address some of the unique needs of particular populations. So that is some of the things that we need to be careful about to ensure that the interventions and processes that we are implementing are both culturally safe and also anti-racist. So I'm not sure if I answered the question, but that's my comment related to that. And in terms of a national strategy, yes, we do need, I think, you know, if there's any good thing, or, you know, I think one of the things that would be good is, you know, creating a national strategy in terms of addressing racism. So as I said, what we have, and I have focused in my discussion on Black populations, there is also other anti-racism strategies that are with other communities too. And what we do not have in Canada is a national anti-racism strategy for health workforce in Canada that then also links the anti-racism strategy to also improve health outcomes for populations with accountability and evaluation embedded within it.
Bukola, thank you. That's a really nice summary of what we talked about. We are making some progresses, but we have miles to go. Hopefully it's not 500 years and we can make major progresses with these kind of initiatives that's happening at the systems level. So thank you to all the presenters and thank you all of you.